Good morning, everyone. In case we had forgotten, because we've been so distracted by so much else that has been happening, there is still the COVID challenge to deal with. India is now inching towards 7 million officially recorded cases, where a serological survey suggests that the number of those who are infected and already over the infection have possibly shown no symptoms is much, much, much higher. We're now looking at 100,000 officially recorded deaths. And questions persist. Are we ready for a complete unlock? Should we start sending our children back to school? How much of economic activity can go back to the way it was pre-pandemic? For the answers to these questions, we need data. We need neutral data. Now, of course, data too is often interpretative, but sometimes it can tell us more than our own anecdotal experiences. On the program today, we'll be looking at the first major study of how COVID is actually transmitted in India. This is a study that has been concentrated on two southern states, Andhra Pradesh and Tamil Nadu. It's been led by epidemiologist Ramanan Laxminarayan, whom I'm going to introduce and welcome to the program in a moment from now. And this shows up some really, really startling and interesting and informative data. So let's welcome Ramanan to the show. Thank you. Good morning. And it's a pleasure having you on. Let me start by first understanding what this survey was looking at. I know it was recently published in Science, in the journal Science, which is very well regarded, taken very seriously. And from what I understand, Ramanan, it was research based on tracing more than 3 million people. So before we get into what this survey actually tells us, can you tell us a little bit about how many people were surveyed and why this was concentrated only in two states?
So thanks for having me, Barkha. So this is a study that was done in the context of contact tracing for COVID, right from the beginning of the epidemic in the two states of Andhra Pradesh and Tamil Nadu. Now, these two states have a legacy of doing very good contact tracing in the context of HIV/AIDS. And so they had the apparatus to put in place for COVID when this was an issue. And it was extremely time-consuming and tedious exercise. It meant tracking down people who were COVID positive, talking to them to see who else they might have come in close contact with, and then going and looking at about an average of 8-9 contacts of each of these cases, and then testing all of the contacts who they would come in close contact with. And close contact means, that they had shared linens or had hugged, and it was not just meeting someone in the marketplace. And that was the context of the study, in which there were probably 3 million contacts traced, well over 50,000 contact tracers working on this job. And we had reliable data on about 85,000 primary or index cases and about 575,000 contacts, which constituted by far the largest contact tracing data set in the world. And I think it provided a wealth of information to be able to address a lot of questions about how COVID is transmitted and who transmits COVID.
So I've already got actually the first question, which is very specific for you. You mostly answered it, but the question is, what was the exact sample size of the survey? I know I've got more than 3 million contacts, but if to be specific.
Specific was approximately 85,000 primary cases and 575,000 contacts. So that's the total data set, which constitutes about 660,000 people.
So what I want to do at this point is actually take a look, Ramanan, if I may, at some of the major findings, because I found them really interesting, and then we can talk a little bit about them one by one. And this is what the survey actually looks like. 70% of COVID patients do not infect any contacts. This is a really, really interesting figure. Men are 62% more likely to die than women. Right? We play these findings again and again. 63% of those who died had at least one comorbidity. So this tells us, this is a startling figure. 45% of those who died were diabetic. So I think if you're diabetic, you need to pay attention. Another fascinating data, deaths concentrated between 50 to 64 years, unlike in other parts of the world. Children are active transmitters of COVID. We'll try and understand this a little bit more. Same age contacts have greatest infection risk. Meeting people of the same age makes you more vulnerable. 8% of infected individuals accounted for 60% of new infections. This number, Ramanan, really, really stayed with me because, what you're actually telling us here is that there's a super spreader syndrome, that the majority of people will not transmit the infection to other people, but a small group might emerge as super spreaders. So if I pull out that number again, 8%, there it is on our screen, 8% of COVID infected led to 60% of new cases in the people you were surveying. What this intuitively made me say is, why did we need the lockdown then? Why did we need to shut down all of India? We should have had a completely different approach. We should have been concentrating on contact tracing and finding the people who were super spreaders rather than punishing 1.3 billion people.
There's a lot we know today, Barkha, that we didn't back in March. And certainly the understanding of super spreading is a lot better today. It's not emerging just from India. There's a very nice article in the Atlantic, which covers super spreading in Japan, for instance, or South Korea, where this seems to be the way in which the disease primarily spreads. You see this also in what happened in the White House in the US, where a lot of people who were close to the US president seem to have gotten infected all at one go. Now, to enforce, so what we do know is that outside is better than inside. Being inside, creates these conditions. Second, not wearing a mask creates these conditions. And third, of course, that it requires is one individual who seems to be very, very efficient at shedding the virus, who then comes and gives it to a whole bunch of people. Now, if we had hypothetically just only shut down mass gatherings, enforced mask wearing, and shut movie halls, shut down marketplaces, but not really changed other places of transmission in India, hypothetically that could have worked. But if you really think carefully about it, those opportunities in India, given the density of our population, could happen on a public bus. It can happen on a train. It can happen in the marketplace. So what would be a non-spreading event in other countries, given our density of population, particularly in urban area, all become opportunities for that kind of super spreading event. Second, it is very hard in India to get people to comply with things like mask wearing, which now people seem to somewhat comply with, without communicating a seriousness of purpose. And I think that as challenged as I am as you are by the lockdown, in the sense that, I felt it was needed as a measure, but I had also problems with it because, right from our previous interview where I said, how are these people going to make a living if they are shut in at home? But, as a society, we seem incapable of these half measures. We are not able to only have the mask wearing and compliance and not have people, transmit the disease widely. And
I know.
so
I need to push you a little bit more on that because, yes, I understand we're diverse, we're dense, 90 million Indians live in, one-room tenements. I get all of that, right? And I get that we didn't know this then, but now that we know this, at this point that 70% of COVID patients did not infect anyone, and that actually it's the super spreaders you need to find, we know this at a point where contact tracing, Ramanan Laxminarayan, is almost over. No one's bothering with contact tracing anymore. People have kind of given up on that, right? Because the numbers are too big. So isn't it ironic, and doesn't it tell us that we need to go back to a fuller, complete life as we knew it before COVID and focus instead on tracing the really serious cases? Or is that easier said than done?
I think that's easier said than done because there's still a lot of people who are not yet infected. I'm not advocating a lockdown, by the way. And it is simply that we need to be mindful of locations where super spreading can happen. Movie halls would be one. Indoor restaurants, particularly places that are air conditioned, create those ideal conditions. Just because people are in an enclosed space and because they're eating, they're removing their masks. So there are still a lot of situations where these events will happen, and I think it's a hard call. It is going to be that anything which we do to control the disease will involve a loss of livelihoods, no question about that. And this has been the challenge from day one. It has not been costless to take down COVID, but at some point it will have to be a decision, as you say, on how you balance this, and it's entirely feasible that India makes that decision, says, forget it, I'm opening up everything, but we have to then be willing to pay the price as well from a public health standpoint. There's just no halfway here.
Okay. Talk a little bit. I mean, there's lots to talk about, but I know a lot of the audience is interested because it concerns them about what you found out about diabetes in this survey, right? And there was a really startling data point that leapt out from there. And you said that about 65% of those who died had one comorbidity, and I think 45%, if I'm remembering the number correctly, of those who died were diabetic. Now, there are questions that are coming in saying, when we talk about comorbidity, do you mean when the ailment is out of control in the cases of diabetes, or do you mean even controlled diabetes? And I think that's an important question.
Yeah, so these are uncontrolled comorbidities, not controlled ones. So this is if the person was actually diabetic and was not really on medication. Now, keep in mind that this is you have to understand that a lot of Indians are diabetic. So the chance of finding diabetics in a population of people who are dead is not uncommon, just because a lot of Indians are diabetic. Now, we were not able to calculate in this study the risk of dying if you were diabetic. That's not what we're saying. We're just saying that 45% were diabetic, 63% had one comorbidity, and I, I also think that we might have an underestimate here because a lot of people don't even know that they're diabetic, right? So, but it is without question that the comorbidities are an important part of driving, mortality, and I think controlling BP and diabetes is definitely helpful.
So the questions keep coming about when one can go back to normal and what this data tells us about that, right? And so some of the other interesting findings is on same age contact, that actually if you're meeting people your own age, you're more likely to be vulnerable. Then the other question is, about your finding on mortality. Now, this is different from anywhere else in the world. And even when you started looking at this data, and I remember interviewing you back then, the assumption everywhere in the world was that it was the elderly who were most vulnerable. And I remember when I was traveling across India and reporting on the pandemic, I would keep saying that people I meet who are dying, the relatives are those of my age, which is like I'm almost 49, and the people I was meeting were roughly between 50 and 60. And your number is mortality in India concentrated between the ages of 50 to 64. How do you explain this?
I think when we spoke back then, I had spoken about the fact that the immune age of Indians is higher because people have comorbidities at this age group, and a greater proportion have uncontrolled diabetes and hypertension in our country compared to other countries, and plus all of the other things like exposure to air pollution and chronic pulmonary disease and things of that nature. So that would explain why this age group is particularly at risk in India. But the interesting thing is that in the older age groups, which you also put up, the above 80, above 85 age groups, mortality in Indians is actually on the lower side compared to other countries. It's much higher in the United States, for instance. And that could reflect what we call a survivorship bias, which is that people who have already made it to that age are generally, healthier. They don't really have that many comorbidities because otherwise they would have, died in an earlier age itself. So it reflects, that survivorship, and that's why we might have fewer deaths in the older age group than we would have predicted back in March.
Okay, now there's a couple of interesting questions. Your own data says that 71% do not infect anybody, and 8% you found accounted for 60% of the cases. So if you juxtapose that with the fact that we know that 80% of people actually recover quite well, and the questions again and again come, why should life not go back to normal? And then there's another question that actually says, why are some people without any underlying comorbidity infected with COVID, and you feel that you're about to recover, and then they die suddenly? And then, there are any number of questions telling us how little we actually still know about this. Is one gentleman writes saying, my uncle got admitted for COVID. He came out diagnosed with a heart and a prostate issue, which had long been dormant, and he didn't even know about it. So people are sharing these experiences. How much do we still not know, Ramanan?
There is a lot we don't know. You have to understand, this is an encounter of human beings with a virus that we have never been infected with before. Even in 1918, there was a familiarity with the flu virus because flu viruses infect us. Here is a case where it's a completely new virus. The virus also doesn't really understand us very well. So it's going out there and trying to find ways in which to survive. Now, take tuberculosis, for instance. we've had tuberculosis with us for tens of thousands of years, possibly hundreds of thousands. So compare that time span of us and the disease, and then our understanding of it compared to this novel coronavirus, where our experience with it is so short. I mean, this disease will be with us for a long time, but we are still figuring out all the kinds of damage it can do. And the other part is that the evidence from many countries seems to suggest that there are long-term consequences of COVID infection. They call these the long haulers. Chronic fatigue syndrome. We really don't know what the impact will be of COVID on people 5 years into the future or 10 years into the future, right? We just don't know this. So there's a lot that we don't understand, which is why public health experts would advise that the best thing is to avoid getting infected by this virus and trying to hold off till we get the vaccine. Understand there's consequences of doing this, but let us not assume that infection is benign with this virus, because we simply don't know. And
So,
mortality is not the only endpoint here.
So I think there's, yeah, we are, I've personally interviewed a number of people who've spoken of chronic fatigue, hair loss, not recovering their whole life, even after they've recovered, anxiety. So there are all kinds of things going on. But the other question, and I want you to connect your data findings with this question. When we know that 80% of people recover, 71% do not infect anyone, the question is, what do we know about the immunity development once you've recovered, right? I have personally tracked, and I want to flag that these are still outlier events, but I've personally tracked about 23 cases of reinfections in Bombay. Now, we don't know if these are reinfections or if the person never recovered the first time and thought that they did, so I want to use the word reinfections very carefully. But there are questions that persist about the fact that once you've got the antibodies, once you've got COVID, can you get it again?
Right. So much of what we know here, again, is from other coronaviruses. We don't know this reliably from this COVID, this particular coronavirus. So generally, there is some period of immunity post any infection. The immunity may wane after some time. Malaria, it wanes over a period of a year, and then you can get reinfected. But it is generally unlikely that someone will recover from a COVID infection and then get reinfected the very next day, just because the body has some residual immunity, simply because it was that immunity that got the virus out of your body in the first place. How does the virus really leave us? It's because the body fights back, and then the virus leaves. Otherwise, the virus has no interest in really leaving us at all. So the fact that we have immunity is what causes us to see an endpoint to the disease. Now, how long that memory lasts is something that's up for question. The evidence from MERS and SARS from before indicates that this can be between 1 and 2 years. It is not lifelong like measles. It's not immediate or no immunity like it is for gonorrhea, for instance, which really doesn't confer much by immunity. So it really differs by disease, and we're still, finding out. See, a lot of this, Barkha, is that's why we need these kinds of large studies, and particularly out of India, where we have the numbers to do it. If we don't do it, we're never going to find out the answers to these kinds of questions, and we'll be stuck with just guessing this sort of thing. But then again, comes down to you've come back to the beginning, which is the value of having a generalized sort of a lockdown. Uh, this is a tough question. It is true that a few people super spread, and I want you to unpack. I want you to understand the super spread, the phenomenon. It's a combination of some people being more prone to shedding the virus for reasons we don't understand. Some studies seem to suggest that these tend to be people who are more likely to be symptomatic than asymptomatic, but we don't know this fully yet. It could be people are asymptomatic as well. And they also happen to be in a situation, like in a movie hall, like in a restaurant, where they then go spread it to many people. So super spreading requires two things. It requires that person. It requires many people who are susceptible. It also requires, an environment, in which super spreading can really happen. And it is because that in India we have many of these kinds of environments compared to Sweden, where you won't see a bunch of 40 Swedes gathering in any place generally. It's just not. Whereas any place in India, there's going to be 40 Indians just by definition. That's what makes us.
But rewind to your own thoughts a few months ago. What was in March when I first interviewed you, and you were a huge advocate of the need for a lockdown, because that's the tool that the world knew. I remember being a a kind of resigned advocate of the lockdown till I started traveling, and I understood that this isn't working. This isn't working for our country. But we persisted with it because I think there was such panic, and there was, nobody knew what else to do. Now that we know this, why are you not coming out and saying more unequivocally that actually just unlock?
Because I think that if you look at, again, our data, it's in one of the supplementary tables. If we had not had that lockdown, we would have had a reproductive number around 4. The disease would have really taken off in a massive way. The numbers of hundreds of millions, which I spoke about by July, would have happened, because we're now seeing that number now, in spite of all of the lockdown that we've done, right? So you mentioned at the beginning, we have 7 million actual, whatever, reported infections. But the serology study indicates that that number is probably, anywhere between 40 and 80 times that number, depending on which serology study you pick up. So clearly, the fact that these large numbers,
right? But that's a good thing, right? Because it suggests localized herd immunity. I mean, I hesitate to use that phrase, but if there are masses of Indians who've been infected, didn't even know, or mostly asymptomatic, or thought they had a mild flu, have recovered from it, have gone on with life, to me, it makes me question the lockdown even more. What the serological service tell us.
Agreed. So, Barkha, just keep in mind that everything you observe up to today is the result of there being restrictions on movement, right? So, during this period, there have been no trains, no widespread travel. The metros have mostly not run during this period of time. If we were to completely open up, go back to life as normal, you should be prepared for, I'm not saying it's not worth it, I'm just saying you should be prepared for there being a spike in cases, because that is what you will see around the world. What we are seeing is we got to this, whatever, 250 or 400 or whatever the number is, million people infected point, in a slow way because of the restriction on activity. The question is, if we've gotten this far, we've probably traveled a third of the way. We have another 2/3 of the way to travel before people are all fully infected. Do you want to travel at the same speed, or do you want to go faster and say, I don't mind having vastly more infections over the next 3-month period? Let's unlock everything. That's also a possibility, but be prepared for there to be, far more. All the damage we saw in the last 6 months with respect to infections and deaths, expect that to be compressed into a 3-month. So, yeah,
okay,
that's all.
We could debate the lockdown forever, but I've got more findings in your survey that I want to talk about. And children, this is the sensitive subject. Schools remain closed. There's huge debate over whether schools should open. Now the central government has said that states must make their own decision, and there has been an argument about a phased opening of schools, a blended model. There are all kinds of things on the table. But first, let's look at what your data actually tells us about children. Now, we know that your survey concentrated in Andhra and Tamil Nadu, published in Science recently, talks about children being silent spreaders. Can you explain that?
So the silent spreader simply means that children are asymptomatic, but they're capable of transmission. Now, let me also clarify what we are not saying. We are not saying that children cause the bulk of the epidemic. We're not saying that children are the most important part of the transmission chain. What we are saying is the research to date from many countries seems to, imply, although because it's based on much smaller data sets, that maybe children are not, not transmitters of COVID. And all that we're saying is no, that doesn't seem to be the case. We have limited data on children, but the children seem to be transmitters, even though they are asymptomatic. Now, for a variety of reasons, children are not going to get picked up as index cases because they're not symptomatic. People don't go test children as much, all of that stuff. So all that I'm not saying that, we should not reopen schools because the children are the big drivers of the epidemic. It is simply that pay attention to the fact that children also do transmit, and the fact that other countries which did open up, and there's not schools, there's also young adults, right? So there's colleges as well. That Israel opened up its schools and they had another spike and they went in for a second lockdown. That's happened in the US as well, where some colleges opened in an uncontrolled fashion and then they had to lock down again. So if we're going to open schools, let's do it with a plan. Let's do it with surveillance. And I think, Barkha, if I had to have one takeaway from this entire interview, which is that I agree with you that a generalized lockdown is not the way to do it. I think going forward, we need much better data-driven stopping of this kind of super spreader event, this sort of cluster containment, which is very data driven, is the way to do it. It is not about this contact tracing kind of method, which I agree with you. The time for that came and went a long time
Yeah.
ago. So
Yeah.
now it has to be that we have to be much smarter of finding these events where a lot of people are getting infected very quickly and trying to shut down those events one after the other, which is really the approach that South Korea and to some extent Japan also took to the epidemic. That requires a significant amount of real-time data crunching and responsiveness. I think we're fully capable of it, but that's what it's going to take to not go into lockdowns.
So to me, when I look at your study and it tells me that children under 14 can be silent spreaders, that there is a danger of child-to-child transmission, what the press release and what I've read so far does not tell me is that if they get infected, how bad is it, right? So I think that do we not need to be asking the question, uh, if you get it, or making the statement, if you get it among children, it's not such a big deal. Their immunity is generally high. They generally cope quite well. They generally recover quite well. What did you find when you went deeper into the question of children and COVID?
So we found that they're generally more asymptomatic. I think that's true around the world. However, we're not looking at clinical outcomes. So kids are obviously not, I mean, the chance of a child to die in our study or anywhere in the world is extremely low, extremely low. It's about 16.5% for someone above the age of 85. For a child, it's 0.01%, something, vanishingly small. That said, let me also say that we don't know the long-term effects of this virus. So we don't know what exposure to the child does to in later age and so forth. So let me also provide that caveat, not as a way of worrying people, but just to be very clear about what we know and what we don't know, right? So we should be absolutely clear about that. What is clear is that today, if a child were to be infected with COVID, the risk to themselves remains extremely low. It's probably similar to getting a flu in terms of outcomes. It is really the potential for them to transmit to elderly people that is a problem. It's a potential for any sort of long-term consequence that we don't know about.
Right. So if you were asked a direct question on reopening of schools, and let's keep in mind that you did speak about other parts of the world where schools opened, there was a spike and they had to shut down again. I think the question that we have to confront, the elephant in the room, is should we be ready to deal with spikes without getting anxious?
See, if you do it in a way that is uninformed and just say, I'm going to just open the school up and not test, then we are in for trouble. But let us say that we went in with a thought process on a testing program at schools and opened the schools with some amount of data visibility on what's going on with the children, whether they're being infected, whether there are clusters of infections in certain schools and so forth, then we should absolutely do it. Let's be clear, we are in a new world right now with COVID. We all want to go back to the old world where people will not have to be tested, or where you can go back to your normal life. At least for the next 18 months, that is not going to be the case. I think that's the thing that people need to understand. We can open the schools for sure, but let us open it with a testing program, with a thought process of how we will deal with things if there's a cluster of cases. Let's go in with that plan and then open the schools. But
So
let's not, we can go to the pre-COVID era and open the school that way.
are you are you a parent, and if you are, would you send your children to school?
I would hope. I am a parent. I have two children in school here and one in college, and they're of different ages from 11 to 19. The 19 is in a college which actually tests every week. Every child tested every week. Now, for the children, they're in homeschooling or whatever, online schooling. But I think that if they were to go, and again, the risk is not particularly to them. The risk would be to elderly people at home, for instance. That's what I would be primarily concerned about. And I would want to see if the school is actually, what measures the school is going to put in place to do some amount of testing and tracking to ensure that there doesn't end up being a widespread outbreak in the school and none of us knows about it until there's been like a whole bunch of people got affected by it. That's what I'd want to see.
Sure. Now, what did doing this study tell you that you did not know, let's say in March? We're now in October. And I ask you this because One of the early sort of set of interviews you did with me and certain other media colleagues had people gunning for you, calling you alarmist because of the numbers you put on the table. And at that time, you had projected pre-lockdown, there was no lockdown then, up to 300 million cases and 2 million deaths. And I remember after I telecast that interview with you, you were like, the Prime Minister understands how serious things are, otherwise he wouldn't be doing this national lockdown. But you got really scrutinized for that data. And I want to ask you today that given this new survey, what do you say about those previous projections? Were you wrong? Were you alarmist? Had you overestimated it?
So I would say that, so again, with the reminder that we were making these projections with no inkling that India was going to go into a lockdown, right? We couldn't call for things, but it's up to the government to do these things. In the absence of the lockdown, we had said that there'd be a few 100 million cases of COVID. Now, did that come to pass? Yes, because the serology studies seem to indicate that even with a harsh lockdown, that came to pass. So I don't think we underestimated the numbers of infections at all, because because that was the easier piece to predict. I think on the mortality at that stage, we had literally no information on mortality rates in India. We had some information out of the Chinese. That was pretty much it. I think that, first of all, mortality in India is underestimated. I certainly think we have more than whatever the 80,000 or 100,000 deaths. I think we're undercounting by a factor of 4 or 5. But even so, I think that we at that stage, we were using a mortality rate of about, 0.8 to 1%. Is it possible that that is the mortality rate now? I think it's lower now. It's because that the lockdown enabled a delay in cases so that the medical system was better able to take care of people. And your chance of dying today of having severe COVID is significantly lower than what it could have been back in March. We found that in our study. So we found that people who had been tested positive in March or April were about 13% more likely to die than people who were tested 2 months later, were about 26% more likely to die than people who were tested 4 to 6 months later. What it tells you is that the intent of that lockdown, and I'm not defending the lockdown just for the lockdown's sake, I'm saying that we were trying to delay the cases somehow. I think that delay helped because today clinicians don't lose as many people to COVID as they would have 6 months ago, just because they know how to deal with these cases. So in that sense also, the mortality will come down because, again, we were projecting for a world where we were going to see that flood of cases happen at that point in time. If I had the chance to reflect back and say what would have happened, back then, knowing everything we do now, I think we would have been in for the numbers that I projected you back in March. I stand by those projections.
You stand by the projection on the infections or on the mortality?
On the mortality as well. On the mortality as well. I think that when you adjust for the fact that that we're undercounting now, that you adjust for the fact that we're seeing lower mortality because of improvement in medical care. If I had to go back and with the information today say, if there's no lockdown, what would have happened back in March? I think we would have headed for that 1 to 2 million deaths and hundreds of millions of infections. That would have certainly come to pass because there's nothing, it's not like the mortality rate has come down vastly. It has come down, like I said, by about 26% as far as our study goes. Now, that said, I think going forward, the projection is a lot better because we have much better survival rates. I think any critical care doctor that you speak to, Barkha will tell you that they're losing only about 40 to 50% of severe COVID cases today, where they would lose about 80% of them back in April. So I think things have changed a lot. So we are in a better world from that perspective.
So just one more question on this, because you're saying you essentially stand by your numbers and the intervention of the lockdown, the progress in science, medicine, treatment, therapy has brought down certainly the mortality. But in terms of the infections, even with the serological surveys, even with under-testing and all of that, our numbers are less than 7 million. Your projection was 300 million, I think, by sometime now or even earlier, by July, August, right? Yeah. Even if that's 40 times... Sorry?
With no intervention, with no lockdown.
With no intervention, the caveat being with no lockdown. That was the extreme scenario. Do you think that the infections have, the data bears out your projection on infections? And if so, how?
So back in March, the serology study conducted by ICMR indicated that about 7 or 8 million Indians were infected. At that point in time, the actual number of infections that were reported were about 60,000. 60,000. Okay, and we're talking about 7 or 8 million infections. We were undercounting by a factor of about 100 back in April itself. Okay, now since then, the serology studies, regardless of the part of the country, regardless of who's doing it, have indicated that we're undercounting anywhere between about 40 to 50 all the way to over 100, 120. So that is the level of undercount of the reported cases compared to true infections. If today true infections are at 7 or 8 million, is it inconceivable that 50 times 8 million, which is 400 million, is the actual number of people who have been through infections today? I mean, give or take 100 million. I mean, remember, we are not counting that precisely here. I think that's absolutely true, and I think any epidemiologist worth their salt would agree with that. The fact of the matter is that we are under testing, and you can look at Pakistan as a comparator. And I bring up Pakistan only because people ask me this question: why does Pakistan have half the mortality per capita of India? Pakistan has half the mortality per capita of India because Pakistan has the testing, which is 1/4 that of India on a per capita basis. So if we don't test, we're not going to find the disease. You find that same distinction within India itself. The states that do a good job of testing, whether Maharashtra or Tamil Nadu, Andhra Pradesh, Kerala, Karnataka, these all are states that are showing up a lot of infections as well. And if you don't test, then it's just going to be a silent and a buried epidemic.
But do you think that now we know that fewer Indians, for reasons that we do not understand, different age group as well as your own study shows, between 50 and 64, there are more deaths, but fewer Indians are dying from COVID than we previously feared? In other words, the IFR, the infection fatality rate, is significantly lower than in other parts of the world. And that will, of course, at some point will be juxtaposed with your projection of 2 million, 1 to 2 million deaths, minus any intervention. I need to keep underlining that.
Yeah.
Do you think you got your understanding of mortality totally wrong? Now, given what you know now,
Again, to go back, given the mortality that we would have expected back in March or April, I think that's what would have happened, which is the 1 to 2 million is what we were on track for, even knowing what we do now. I mean, today's information is based on how medical science has progressed. That's what it reflects. It's not the underlying part of the disease. Now, the infection fatality rate, let's talk about that for a second, because there's a lot of misunderstanding about this.
Yeah.
There is a perception that perhaps India has done far better than other countries. Now, India today ranks somewhere, I haven't checked recently, but it's probably number 70 in the world rankings for deaths per capita. It's probably about 75 for infections per capita. India is 108 on testing per capita. So we are worse than average on testing, and we are higher than average on cases per capita, adjusting for our population, and also deaths per capita. I don't think there is strong evidence that we have performed better than the rest of the world. And I don't think, again, I don't put it down to India as fighting this battle on its own and performing. I think India has done extremely well. I'm impressed by a lot of the public health response. And in fact, I was telling a reporter yesterday, she was asking what the difference was between the US and India. And I said, US had the health system, but not the leadership. And India had the leadership, but not the health system. And this is really where we were really lost, because we don't have the systems to fight COVID in the way that other countries do. So given that, we've done actually quite well. So let's be very clear. It could have been a lot worse than what is going on right now. But that said, I think this infection fatality rate story that we are somehow better than other countries is not really true. You will find that people who test more have found more, people who test less have found less. And that captures a lot of the story. And these numbers will come to light much better in weeks and months, ahead, as there's more research happening. And let's just not go off of the numbers we have right now, because we don't have a good understanding of the epidemic.
So largely for that time, minus the intervention, you stand by your projections.
I think so. I think we were not wildly wrong. I think that's what we were on track for.
Okay, let me in the end spend a few minutes going back to your study. There are also questions that are actually coming for you. So I'm just going to play the key bits of the study again. The questions are, really about whether the lockdown was too soon, the peak is too high, is there anything the central government could have done differently? These are the kind of questions, Ramanan Laxminarayan, that we are getting, and I think that there's an interesting question in saying, okay, given what we know, what could we have done differently, and can we still do it?
I think, again, it's hard to second guess always at that point in time. If we had tested more back in March, if we had identified clusters much better, it's possible that we didn't need a national lockdown. In fact, I wrote about it, others wrote about it, and it was concerning us that the testing was just not high enough. And we were subjecting places like Arunachal Pradesh and Meghalaya to a lockdown when they probably had zero cases, right? So this is something we knew back then. It was not the preferred option to lockdown nationally. But that said, what our study finds again is that the reproductive number did come down from about 3.5 to 4 in these two states down to 1.5, which means the average person was infecting only another 1.5 people. And it stayed consistently low for the entire period from March through to now. So if you're looking for evidence of a long-term effect of the shutdown on the reproductive number, we find that. We find that quite strong. Now, you can go back and project how many cases we would have had without the lockdown, etc. That someone else can really do. Are there things that we would have done better? I'm sure there's always things which reflect how the lockdown was put into place that could have done much better. I think going back, the risk that migrants would have posed to rural India by being allowed to go home over a 4-5 day period or a week-long period before imposing the lockdown would not have been particularly high. I suspect that is what drove the government to try to impose a very sudden shutdown. I'm sure they were not trying to deliberately inconvenience people. They just thought if we let all these people go back, then it's going to spread the epidemic everywhere. Possibly that risk was overstated at that point in time. Again, no way to know except with better testing. I also think that this is not the question of this interview, but really many things could have been done to make life easier for folks in the question of economic hardship and so forth. But
Of course,
but,
yeah.
but the challenges we're facing, Barkha, is really, I was in the US last week. Life is the same throughout the planet, everywhere. People are all staying home. People are all wearing masks. It's almost like the whole world is unified in what we are going through is not just us. It's the entire world is going through this at this point in time. And it is tough.
Okay, I have a couple of minutes left. But the questions you mentioned the US, there's a question that's come in about universities that are testing students every week. I think you mentioned your own child, being a college student and going through that. Is that the way forward to have those on the spot rapid testing, whether at airports, whether at schools, whether at restaurants? That it's just a different way of life, but at least it helps you get back to a life that you knew.
I think that's really the only way I can think of, which is uh, these are not so much about testing to contain the disease on that particular student. It is to keep an eye on what's happening overall. So without that eye on the ground, we will not really have any control of the epidemic. So I think we should open up, but with significantly more testing so that we're understanding where there are clusters of infection and areas of service.
So just in terms of daily life, because we're now at the point where in the capital, cinema halls are going to be allowed soon at 50% of their capacity. Restaurants are open. Restaurants are opening in many other cities, but of course all at lowered capacities. There's a huge debate on in America. The CDC seems to keep changing its mind on the issue of aerosol or air spread. Right? Do we know anything about that in terms of this survey?
So the CDC, not from this survey, we didn't look at aerosol versus droplets. Today, the CDC has clarified again, and literally
Yes.
yesterday, that, and I think this is, generally most scientists would agree on this, which is that in indoor environments, there seems to be some lingering of the virus in the air, right? That's basically it. If you can avoid indoor environments where you're with other people who are not wearing masks, that will help a significant amount. So I would say don't get into this aerosol droplet discussion because that's highly technical. If you can avoid non-mask inside spaces, that's really the thing.
A quick question on the waves, the fact that other countries, US and Europe, are talking about multiple waves. There's a huge debate on whether India has even completed its first wave.
Barkha, the wave concept is actually much more a public discussion than there is no technical definition of a wave. I mean, this is not an epidemiological concept of having a wave. What you observe as a wave is the consequence of these lockdowns in places like Italy, which then bend the curve. And then when you remove the measures, the curve comes back. That's all it really means. In India, we never bent the curve. So where are we going to have, multiple waves? I just think that our effort should be on controlling mortality and keeping a cap on the disease than worrying about the waves.
Literally a last question on the role of the World Health Organization. It's constantly changing prescriptions. I remember a time when the WHO was saying, leave the masks for health workers. Like, I remember that time, and we've all forgotten that time. Now, should we be agitated, or is it just that we knew so little that you can't actually hold people to account on the things they said 4 months, 5 months ago?
So, Barkha, I'm going to take a minute over this answer because I want people to understand WHO. WHO is not somebody else sitting somewhere over there. WHO is us. I have worked with WHO as an advisory panel member, as even being on committees for the last 25 years. And we have systematically starved WHO of resources. This is the world's organization. We have not given them the capacity. WHO today, without doubt, is a shadow of what it was 25 years ago in terms of personnel, in terms of resources. The average small, hospital in the United States will have a bigger budget than WHO does, right? Or for a county system, whatever. So it is, if you don't put in the resources into a global organization that's responsible, how will they be able to do the public health, be able to, do the work that they need to? Now, without question, they have made mistakes, without question. And I think that there are many things that should have happened earlier. On hindsight, they should have declared a public health emergency of international concern a fake, probably a month before when they did. They've been slow on masks, they've been slow on many other things. But let us also say that this is not some organization that is run by somebody else. This is an organization that India pays into. And the lesson for us is, let's now triple our contributions from every country and make WHO an organization that works for us. And that is the appropriate response.
Okay. And quickly to close this conversation, the one major takeaway for me, it's what I've put on the screen. 70% of COVID patients did not infect anyone. How do you know who the super spreader? For a government, when you hand over this data to Andhra and Tamil Nadu, you're telling us that there's a super spreader syndrome, that 8% of COVID infected led to 60% of new cases. How do we find these super spreaders?
That's a great question. We have some work ahead of us. We hope to have more information out soon, but at the current time, we were not able to complete that analysis just yet, but we are looking to do that as much as we can. Not just super spreaders, but also the context in which super spreading happens. But do stay tuned. This is the big question that's out there in front of us. So, but we will definitely be working. We are working on it, actually.
Okay, fascinating data. I think every few months we're going to have new information and a new understanding of what's going on. It's a very fluid situation. Doctors, epidemiologists, the World Health Organization, governments are sounding like they're changing their mind all the time because new information is coming our way all the time. Thank you, Ramanan Laxminarayan. It's been a pleasure. You've taken a lot of questions as well. There's lots more coming, but I'm sorry I've run out of time. This program is up on our platform for anyone to go back, look through it, and if you have more questions, we will try and forward them to the epidemiologist, and maybe he can pick up some of the more interesting ones. Thank you so much. Pleasure talking to you. And thanks to our audience. We'll see you in the evening with a new program. We'll be following the Hathras gang rape very closely as well. So more on that later in the day. Goodbye and thanks for watching.